Where is it? Where is it? Can you find it? I can't find it. I feel a lot like Kary Mullis. I don't know if you know Kary Mullis. He's the inventor of PCR testing and the testing that's being used for COVID. Never mind the fact that this Nobel laureate, Kary Mullis, said it was not to be used for diagnostic testing purposes, but we won't get into that right now. And I feel like him because I'm looking for that primary piece of research on COVID. Kary was looking for it on HIV and AIDS, to which he put this in the foreword here. Thus, when I found myself writing a report on our progress and goals for the project, sponsored by the National Institute of Health, I recognized that I did not know the scientific reference to support a statement I had just written. HIV is a probable cause of AIDS. The book goes on to explain Kary's frustration and Dr. Peter Duesberg's frustration in trying to find the source material, the source research that proved HIV caused AIDS. And I share this bit of information with you because I am unable to find the bit of research that proves COVID-19 causes the symptoms it's being linked to. If someone else has that research, I'd be happy to see it. Please let me know. Put it in the link down below in a comment. Thank you for doing that. But right now, I can't find it. And to that point, I want to be part of a society, a scientific society, and a general society that has an open policy, that respects freedom, that respects equality, that essentially encourages questions, encourages challenging the paradigm. That's all right. If the paradigm's good, it'll stand up to questions. And so this video is yet again another set of well-respected experts questioning the coronavirus. Dr. John Lee is an English consultant histopathologist at Rotherham General Hospital and formerly clinical professor of pathology at Hull York Medical School. And he says this: but there's another, potentially even more serious problem: the way that deaths are recorded. If someone dies of a respiratory infection in the UK, the specific cause of the infection is not usually recorded, unless the illness is a rare notifiable disease. So the vast majority of respiratory deaths in the UK are recorded as bronchopneumonia, pneumonia, old age, or a similar designation. We don't really test for flu or other seasonal infections. If the patient has, say, cancer, motor neuron disease, or another serious disease, this will be recorded as the cause of death, even if the final illness was a respiratory infection. This means UK certifications normally under-record deaths due to respiratory infections. Now look what has happened since the emergence of COVID-19. The list of notifiable diseases has been updated. This list, as well as containing smallpox, which has been extinct for many years, and conditions such as anthrax, brucellosis, plague, and rabies, which most UK doctors will never see in their entire careers, has now been amended to include COVID-19, but not the flu. That means every positive test for COVID-19 must be notified in a way that just would not be for flu or most other infections. As well, he said in another piece, few tests have been carried out in patients with mild symptoms. This means that the number of positive tests will be far lower than the number of people who have had the disease. Sir Patrick Vallance, the government's chief scientific advisor, has been trying to stress this. He suggested that the real figure for the number of cases could be 10 to 20 times higher than the official figure. If he's right, the headline death rate due to this virus will be 10 to 20 times lower than it appears to be from the published figures. The distinction between dying with COVID-19 and dying due to COVID-19 is not just splitting hairs. Consider some examples: an 87-year-old woman with dementia in a nursing home, a 79-year-old man with metastatic bladder cancer, a 29-year-old man with leukemia treated with chemotherapy, a 46-year-old woman with motor neuron disease for 2 years. All develop chest infections and die. All test positive for COVID-19, yet all were vulnerable to death by chest infection from any infective cause, including the flu. So to those who don't question the death count, my question is, why? What do you have to refute Dr. Lee's perspective on this, which is quite lucid? Dr. John Ioannidis, Professor of Medicine, of Health Research and Policy, and of Biomedical Data Research at Stanford University School of Medicine and Professor of Statistics at Stanford University School of Humanitarians and Sciences.
When we spoke to you on March 23rd, you said we needed more data before we could ascertain what was happening. Since then, you've been busily gathering that data and have published 3 studies. Let's start with the latest one, which you entitle COVID-19 Antibody Seroprevalence in Santa Clara County, California. What was the purpose of that study, and what did you discover?
We realized that the number of infected people is somewhere between 50 and 85 times more compared to what we thought, compared to what had been documented. Immediately, that means that the infection fatality rate, the chance of dying, the probability of dying if you are infected, diminishes by 50 to 85-fold, because the denominator in the calculation becomes 50 to 85-fold bigger. If you take these numbers into account, they suggest that the infection fatality rate for this new coronavirus is likely to be in the same ballpark as seasonal influenza. Of course, there is still a little bit of uncertainty about the exact number, but it's clearly very different compared to the original thoughts or speculations or preliminary data that suggested a much, much higher infection fatality rate. Then there's other problems. There's all that meltdown of mental health. There's child abuse. There's domestic violence. We already see hints that these problems are escalating. Violence in general. We see that gun sales are escalating, and I do really worry about people who are locked down and desperate and losing their jobs and just feeling completely lost in a world that they cannot understand how it is evolving and why. It's very, very difficult to fathom the consequences of what is going on and what we're doing. But I really worry that unless we manage to have a viable plan to exit from lockdown and shelter in place and reopen our world, the consequences will be far worse than coronavirus.
Professor Knut Wittkowski is a German-American researcher and professor of epidemiology. He has worked for decades at the Department of Biostatistics, Epidemiology, and Research Design at the Rockefeller University in New York. And what he says is this: with all respiratory diseases, the only thing that stops the disease is herd immunity. About 80% of the people need to have had contact with the virus, and the majority of them won't have even recognized they were infected, or they had very, very mild symptoms, especially if they are children. So it's very important to keep the schools open and kids mingling to spread the virus to get herd immunity as fast as possible. We are experiencing all sorts of counterproductive consequences of not well thought through policy. I have been an epidemiologist for 35 years and have been modeling epidemics for 35. It's a pleasure to have the ability to help people to understand, but it's a struggle to get heard. Again, it seems as this is coming from a credible source. I may not entirely jive with his perspective, but he's a respected epidemiologist in society, just as Dr. Fauci or whoever on the president of the US state or German state or whoever, Italian state, whatever state, they're epidemiologist or immunologist or virologist. These people are on even par with each other. Is Professor Wittkowski not allowed to hold his opinion? Is it not a valid opinion? Is it not allowed in a free society to have different opinions about how health is created and how health is maintained? Dr. Klaus Püschel is a German forensic pathologist and former professor of forensic at Essen University, and current director of the Institute of Forensic Medicine at the University Medical Center Hamburg-Eppendorf. And contrary to the guidelines of the Robert Koch Institute, his office in Hamburg has started to differentiate between deaths with and deaths from coronavirus, which led to a decrease in COVID-19 deaths. And he says this virus influences our lives in a completely excessive way. This is disproportionate to the danger posed by the virus, and the astronomical economic damage now being caused is not commensurate with the danger posed by the virus. I'm convinced that the coronavirus mortality rate will not even show up as a peak in annual mortality. All those we have examined so far had cancer, a chronic lung disease, were heavy smokers or severely obese, suffered from diabetes, or had a cardiovascular disease. The virus was the last straw that broke the camel's back, so to speak. COVID-19 is a fatal disease only in exceptional cases, but in most cases, it is a predominantly harmless viral infection. In quite a few cases, we have also found that the current coronavirus infection has nothing whatsoever to do with the fatal outcome because other causes of death are present. For example, a brain hemorrhage or a heart attack. COVID-19 is not a particularly dangerous viral disease. All speculations about individual deaths that have not been expertly examined only fuel anxiety. It's a big point what he's saying. He's saying essentially susceptibility is what determines whether someone will have a bad outcome with this interaction. Dr. Alexander Kekulé is a German doctor and biochemist. He has held the chair for medical microbiology and virology at Martin Luther University, Halle-Wittenberg since 1999, and is the current director of the Institute for Medical Microbiology at the University Hospital Halle. What he says: it's impossible to wait for a vaccine. The quickest we could have a vaccine ready is in 6 months. Based on experience, I'd say the reality is closer to a year. We can't stay under lockdown for 6 months to a year. If we did that, our society and our culture would be ruined. People under 50 are very, very unlikely to die or get seriously ill from the coronavirus. We have to let them get infected so they can develop immunity. Again, I may not see the validity in the herd immunity model, yet this man is considered respectable in his field. So why is his position not considered respectable in a free society? It seems like it should be. Dr. Klaus Püschel is a German internist based in Kiel and co-author of the book Virus Mania. And what he says is, the coronavirus test is a PCA-based test, where false positives are programmed in. Half of the positive tests could be wrong. PCA tests often show false positives. You can ask Professor Gigerenzer in Berlin about this problem area. The tests are very sensitive. If you have only one molecule of something, the test can show positive. That doesn't mean the patient is sick or that he has coronavirus. It doesn't get isolated, but one relies wholly on these tests. The spreading panic is in large part founded on news from Italy, and nowadays, one doesn't know how much of it is fake news. I have seen Italian doctors online where I have compelling suspicion something isn't right with what they say. I am a clinician, and I don't see a new disease on the horizon. If you took away the test, life would go on as before. There wouldn't be anything to see. Dr. Gérard Krause is the head of Department for Epidemiology at the Helmholtz Center for Infection in Braunschweig, director of the Institute for Infectious Disease Epidemiology at Twin Core in Hanover, and chair of the PhD program Epidemiology at the Hanover Medical School. And what he says is this: we have to keep these serious social measures as short and as low as possible, because they could potentially cause more illnesses and deaths than the coronavirus itself. Although my focus is on infectious disease, I believe that it is imperative that we consider the impact on other areas of health and society. We as a society must not focus solely on the victims of the coronavirus. We know that unemployment, for example, causes illness and even increases mortality. It can also drive people into suicide. Restricting freedom of movement is likely to have a further negative impact on public health. It is not so easy to calculate such consequences directly, but they still happen, and they can possibly be more serious than the consequences of the infections themselves, which is something I've been saying from very early on in this is anytime you impact a society in this way, where you restrict freedoms, you have an economic downturn, it's going to impact the poor and the people in poor health even worse. And unfortunately, there already were large-scale epidemics underway within the Western world. Diabetes, cancer, heart disease, stroke, the opioid epidemic, all of these things will go through the childhood obesity. All of these things are going to continue going up. Remember, they cause death, and almost even worse so than COVID. It's not a short-term interaction with the supposed causal agent and boom, you're dead, but long-term effect, years and years of torture, of pain, of going out in parts, and then death. Does that not count? Continuing on, Dr. Gigerenzer is a German psychologist, professor of psychology, and director of the Harding Center for Risk Literacy at the Max Planck Institute for Human Development in Berlin. And what he says is this: the 2009 swine flu epidemic killed hundreds of thousands, mostly in Africa and Southeast Asia. But in Europe, where the threat was comparatively small, the media updated the death toll and the number of suspected cases on a daily basis. In the United Kingdom, the government predicted that as many as 65,000 citizens might die from the disease. In the end, fewer than 500 died. Predictably, such daily accounting triggered fear and led politicians to make hasty, ill-advised decisions, such as stockpiling medication, without examining the evidence. All eyes were focused on the new, unknown virus, and not on protecting people from the more lethal threats, such as seasonal influenza, which in 2009 killed orders of magnitude more people than the swine flu. It still does. As would be clear if the media bombarded us with hourly updates of flu-related death toll. Similarly, millions of people, particularly in developing countries, die from malaria and tuberculosis each year, and in the United States alone, hospital-acquired infections kill some 99,000 patients annually. Yet these unlucky people get next to no attention. Why are we more scared of what is less likely to kill us? That is a fantastic question. Why are we more scared of what is less likely to kill us? Why aren't we paying more attention to the things that are very much more risky to us, that are way more damaging to our society? Why are we not caring about the major epidemics, the long-standing epidemics that are going on in our society? That's my question. Why are we more scared of something that is less likely to kill us? Thank you for watching this video, and thank you for having the open mind to examine other perspectives on this current situation. If you found it valuable, please like, subscribe, and share this video with others. Until the next video, live joyously, live passionately, keep getting healthier, family.